I'm going to start. I think it's 8 o'clock. So I want to start by just welcoming Jason Chin and Justin Rix from Jason Chin and Associates. We're very fortunate at Vincent Pallotti to have a fantastic amputation service, amputation clinic service there, where we have a proper multidisciplinary team that assist these patients, and I think a very good service that I have really not come across anywhere else in South Africa. So I've asked them, and they kindly agreed to participate in the tutorial tonight. So just I'm going to have a quick talk about limb salvage and versus amputation and the decision making. A few pointers just on the technique of the lower limb amputations, the common ones, and then he's going to be over to Jason and Justin, just an overview of orthotics and prosthetics, and then with special consideration to prosthetic reconstruction for lower limb amputations. So just to go back to the indications for amputations, and like everything, Mike Solomon's have got a good sort of easy way to remember the indications. And we amputate limbs that are detached, damaged, dead, dangerous, or a damn nuisance. Now, we normally come in as orthopedic trauma surgeons in the first two. So detached limbs, that's obviously, mangled and not salvageable, damaged limbs, but also sometimes in the chronic situation after failed reconstruction where the limb is a simple nuisance. Dead, is normally vascular paths and amputation of vascular insufficiency. That's normally done by the surgeons. And dangerous are normally septic limbs, as in, diabetic legs. And again, that's something that's more done by the surgeons than ourselves. So first talk about limb salvage and amputation. It's actually very difficult when you're faced with a mangled extremity to decide when to tackle a complex reconstruction and give the patient an acceptable result in an acceptable time frame, or when it is better to just proceed to an amputation and with a prosthetic reconstruction. And the first concept that I want to just stress is that amputation is not necessarily a failure, and I think one must rather consider amputation as the first step in prosthetic limb reconstruction. So it's not really limb salvage versus amputation, it's limb salvage and reconstruction versus prosthetic limb reconstruction. Just an example, this is a patient of mine. She had a congenital deficiency fibula hemimelia in her leg, and she had more than 20 surgeries through her lifetime. She had a large leg length discrepancy, arthritic, non-functional ankle, and actually late in adult life I did the amputation for her, and she was extremely happy. It's a picture of her swimming a relay to Robben Island, and this is her on the left there with a prosthesis, and you won't even noticed that, and she was extremely happy with her decision to have an amputation. So our aim for prosthetic reconstruction is to give the patient the best possible function in the shortest possible time frame and with the resources available where you work. And that might not be the same for all of us, as some might work in more resource constrained environments than others. So the initial decision making is quite difficult. Sometimes it's quite obvious, like this picture here. It's very unlikely that you can salvage this limb, and it's quite easy to make a decision to go for an initial amputation. Unfortunately, it's not always that straightforward. That's why there's various scoring systems that's been developed, and probably the best known one is the MES score. Unfortunately, the MES score is not that helpful because the MES score really only predicts short-term survival of the limb. So in other words, will the limb survive the initial sort of vascular insult and mangled extremity? It does not include successful reconstruction, predicting successful reconstruction, of the limb, getting the fractures to unite, and so forth. That's why of all the prediction systems, the Ganga-Hoster scoring system to me is the most useful. We'll have a chat about that now. There's also various, just like with pathological fraction pathological fracture prediction tools. There's online prediction models where you can enter all the patient parameters and it can basically predict. But again, it's really based on short-term survival of the limb and not eventual successful reconstruction of the bony defect, the soft tissue, and so forth. So the hospital's Ganga Hospital's score also included late amputation as failures. So they really looked at predicting not only survival of the limb, but successful reconstruction. In other words, successful union of the fractures, reconstruction of the bone defect, and so forth. And the scoring system gives a score from 1 to 5 for 3 different aspects. Firstly, the covering structures. This is the skin and the fascia. Skeletal structures, which is the bone, and then what they call the functional tissue, which is the muscles and the nerve. And with increased severity of the injury, you get a score for more closer to 5. There's certain comorbid conditions which act as modifiers that will add a score of 2. And in any case of more than 14 or more, you should consider amputation. In their series, they actually showed that a score of 16 and more had 100% eventual amputation rate. So even the limbs that survive short term with the so-called 17 or more, eventual had to be amputated for sepsis or non-union or failed reconstruction. 14 to 70 is sort of the gray area. Most of the time, limbs under 14 you should be able to salvage. And this is how the score works. If you look here at the middle score for skeletal structures or bone, you can say a bone loss of more than 4 centimeters scores of 5. Skin and fascia circumferential skin loss scores of 5. And then functional tissue, 2 or more compartment muscle loss scores of 5. And then the modifiers are polytrauma, delayed presentation, age, some comorbid conditions, shock, and other injuries to the same limb. It's very useful, not only to help us make a decision, and we don't have to use this as an obsolete, but it just helps you to direct your thoughts, and also good for medical legal purposes to document this in the patient's file, and that we have considered all the options before we decide to proceed to an amputation. So there's just a few myths that I would like to discuss, and this is what was always used as an absolute indication for amputation in a traumatic situation, and that's absent plantar sensation. It's also something we consider, but the LEAP study group showed us that initial loss of plantar sensation did not really predict eventual failure of limb salvage well. And about 50% with initial loss of plantar sensation, for whatever reason, a nerve contusion or a partial nerve injury, regained eventual sensation. So insensate plantar aspect of a limb should definitely not be used as an absolute indication for surgery. And then the second myth was the fact that patients do better when they have initial, or accept better when they have initial amputations than delayed amputations. There might be some truth to it, but there's some papers like this paper showing acceptable, similar functional and psychological outcomes in patients with delayed amputations. And certainly for some patients, they do feel better if they settle on an eventual amputation, if they feel like everything possible was done to save the limb. So this is just my way of thinking of it. So the decision to amputate or reconstruct a limb in an acute situation is based on the degree of injury. You can use a scoring system here to guide you. It also depends on the expertise available in limb salvage, and this is not only orthopedics, but normally also plastic surgery that's needed. You need to take into consideration the timeline of the proposed reconstruction, especially when it comes to bone defects. You guys know if you have a large bone defect, the reconstruction would often be more than a year or 1-2 years in a frame, so you need to take that into consideration versus an amputation where a patient can sometimes have a quicker return to function with the prosthesis. You need to take into consideration the amputation options. In other words, a below knee option would be a better amputation option than an above knee. And then also you need to look at the patient's access to a prosthetic service, because if there's no access to a prosthetic service, then any residual limb might be better than no residual limb. So from an orthopedic point of view, you need to have the expertise to reconstruct a bony defect, and there's various techniques depending on the size. From a plastic surgery side, you need to have access to microvascular and flap surgery to reconstruct soft tissue defects, to salvage limbs. There's actually very little sort of written on amputation, especially in developing countries. This is quite a nice study where they had two countries participating, a developed world country in the Netherlands and a developing world country as in India. And they looked at the factors that predicted better quality of life in amputees. And they found that those that use their prosthesis regularly and those that remain employed post-amputation were much happier or did much better. And then if you look at this paper from Nigeria, it showed that in Nigeria, only 16% of amputees eventually receive prosthetic. And I don't think in South Africa it's much different, although I haven't been able to find anything published from here. So that just shows us that, you know, in a developing world setting, sometimes if there's no access to a prosthetic service, then any residual limb can be better than nothing. And it's really important for an amputee to have access to a prosthesis and to, you know, to regain quality of life following an amputation. If you compare cost, well, we know that initial cost of limb reconstruction is very high, but that's over time, the cost of the prosthetic service catches up. So in lifetime, especially in traumatic amputation, limb reconstruction is cheaper than prosthetic limb reconstruction. And then the next difficult question in a trauma situation is on the level of the amputation. And this is why I would encourage you guys, we often, like at Vincent Culotti, would consult Jason and Justin and their team when we have someone with a mangled extremity, except for the cases where there's obviously an absolute emergency and the patient is rushed to theatre. It's immediately done. Often it's a sort of, there is time for decision making, and we consult the prosthetist not only in discussion of amputation versus salvage, but also on the level of amputation, and this is based on the individual patient's need. Often where there's a debate is between an above-knee amputation or through-knee amputation. I will chat a little bit about that later. And then lastly, very important, is an amputation needs to be well performed. Unfortunately, it often is a procedure that's done in an emergent situation, sometimes by junior staff, and with sort of suboptimal attention to detail. So we do unfortunately see some amputation that's done poorly, and it's actually very important for the patient's eventual function to have an amputation done well. That's why it's often worthwhile if patients see the amputation clinic and they don't have a well-performed amputation, that we would consider revising it to improve on, you know, on the stump, to improve prosthetic fitting. So just a few aspects, technical aspects on the different levels of amputation in the lower limb. The first one that I just wanted to mention, or actually I wanted to mention just this book. Now, unfortunately, amputation is a little bit of a forgotten art. You know, there's been so much progress in orthopedics. There's a lot written on, you know, all the modern reconstruction techniques, and amputation surgery is not always well taught. There's an old book that a consultant is now retired gave to me that I sort of put in my bookshelf and didn't really look at it, and only later when I had to do more amputation went back to it. And it's actually a very old book, but very useful and showing, you know, good techniques for the various levels of amputations. So a Syme's amputation, which is really a disarticulation of the ankle joint and shaving of the malleoli while retaining the heel pad, is an example of an end-bearing stump. So the patient can bear weight on the end of that stump. When they walk short distances, they don't have to wear a prosthetic. It's an excellent pediatric amputation. And just what's worthwhile to remember here, that remember in congenital limb deficiencies, where children have Syme's amputations, often this limb is not a normal length. So the patient have an end-bearing stump, but it's not the same length as the other limb. In other words, the prosthetic fitting is more similar to a below knee amputation than to a adult size amputation where the limbs are the same length and it's sort of a shoe. So for adults, size amputation, even though it's attractive, is not always that good when it comes to high functioning amputees, and it's often better to be below knee. But Jason can tell us later about that. So below knee amputation is the amputation that's most commonly performed in a traumatic situation. There's a few factors to consider. First is the bone length, how to do your skin flaps, and then some other modifications of the procedure. The bone length, so obviously you want an adequate stump length or bone length in a below knee. It's pointless having a below knee and then having such a short stump that you can't fit a prosthesis. Now, I'd say anything in bone length from 12 to 18 centimeters. I like the old dictum, it's sort of taught in Campbell's, it's say an inch for every foot of the patient's length. In other words, for every foot that the patient's 6 feet long, then you would select a bone length of 6 inches, which is about 15 centimeters. You also don't want it too long, but again, in a situation where there's the opportunity, you can discuss this with the prosthetist prior to the amputation. Talk about the skin flaps. So classically, it's taught that a posterior based flap, as we have in the middle picture here, is for cases of vascular insufficiency where there's better blood supply. For traumatic amputation, you can do a fish mouth. Personally, I feel that, the fish mouth, just because the suture line is directly under the stump, don't do so well, and I'd rather do all the amputation with the posterior base flap just to remove the suture line away from underneath the stump where the patient weight bear. You also see this is another technique for vascular flaps to do a sort of fish mouth in the sagittal plane. Very important to a myodesis of the skin, suturing the fascia of the muscles to the periosteum with or without drill holes. And you can even do this, an example of what's called an extended posterior flap, where you would move the suture line further anterior or proximal below knee to further just to eliminate the problems of having the suture line over the weight-bearing part of a below knee amputation. One thing that I just wanted to mention, because it's a sort of a topical word that's often used, is the Ertel procedure, which is where you aim to achieve a bone bridge. Now, when this was prescribed, there were some very high functioning amputees, and a lot of people with this procedure, specifically from military amputations, and this amputation also became popular, but became topical. It is actually quite tricky to perform. It has a significant complication rate, and it's not really been able to recreate or shown that it's superior to a normal amputation, and that's why I don't routinely perform that for below knee amputation. Also takes longer to heal, and you need union of your bone bridge afterwards. It is useful in pediatric amputation, as an example of a case that I did, where we often struggle with when it's done in a small child with recurrent overgrowth of the stump, and for some reason, once you achieve a bony bridge between the tibia and the fibula, that sort of stop or decreases the incidence of ongoing bony overgrowth. So it is useful in certain situations. Through knee amputation, I think, is a very good amputation. Historically, or certainly when I was a register, people were taught that it's better to do an above knee than a through knee. I don't think that's the case. One thing of a through knee amputation, if it's done in an adult with the equal female length, is that if you have a very sort of bulky knee joint in your prosthetic, you have slightly different heights of your knee. But if you have a sort of more high-tech knee that takes less space, your knees can be at the same, more or less the same level. Now, there's various techniques describe how to perform a through knee amputation. This is the technique I like, which uses an anterior-based skin flap, so different from the other amputations. And the reason for that is you have specialized skin over your patella tendon. When you do a posterior-based skin flap with a through knee amputation, you basically bring the soft skin that's not functional in the popliteal fossa over your stump. And even though you have an end-bearing stump, that skin is not specialized and used to the friction. So if you have an anterior-based skin flap, you bring the specialized skin over the patella tendon that you kneel on underneath your stump. It's important then that you myodese the patella tendon. Another benefit is that, as you know, the quads muscle crosses both your hip and your knee joint. So it is, except for knee extensions, also a weak hip flexor. So if you do lose your quads, you do use a little bit of flexion strength. So if you myodese the patella tendon with an anterior base flap and retain the patella, then you maintain the strength. One of the problems with maintaining the patella is sometimes the patella moves. It can be a problem with prosthetic fitting, but if you myodese it properly, then that's not the case. So this is just an example. So you cut the cruciates distal from the tibia, and then you use the cruciates to do a myodesis, as you can see here, of both your hamstrings. Very important. Remember, your hamstrings are your only hip extensors, and all your hamstring muscles, all 5 of them, cross your knee joint and attach to your tibia. So if you do a through knee amputation, you just cut them and let them retract. The patient has significant loss of power of hip extension. So do it this way. You can myodese all your hamstrings, medial and lateral, to the residual stump of the cruciates, also your patella tendon, and then you end up with a posterior suture line, and it gives a very good sort of stump for prosthetics. When it becomes to above knee amputation, there's really 2 levels: supracondylar level. And the supracondylar level is preferred because you retain most of the muscle attachments on your femur. That's not always possible. Sometimes you have to do a transfemoral amputation, which we'll discuss now. There's a modification described of the supracondylar amputation, the gritty-stokes. I've actually never performed this myself. This is to try and achieve an end-bearing stump with a supracondylar amputation in the femur, where you cut away the undersurface of the patella and you try and get union between the patella and the femur. I've never done this myself, but it is described to basically have a similar stump to a through knee amputation that is end bearing. Very important when you do a transfemoral above knee amputation, your level is above the adductor tubercle, where your adductor magnus attaches to your distal femur. Now what happens then is you have a muscle imbalance, and because your AB ductus attaches proximally to the femur, you end up with a above knee amputation with your femoral stump in abduction, and you lose sort of some of your mechanical advantage during gait and have to spend more energy with walking. So when you do a transfemoral amputation, it's very important to myodese the adductor muscles, and the most commonly used technique or described technique is that by Gottschalk, where you do a more medially based flap and you myodese your adductor magnus around the femur. You can see there you have a longer medial flap, and then you end up with a suture line that's off center to lateral, and also to avoid having your suture line under your stump in an above knee amputation. So to summarize then, the decision to amputate or reconstruct a limb in a traumatic mangled extremity situation depends on the degree of injury. You can use a scoring system to help you make the decision. It depends on the expertise available in limb salvage, both orthopedics and plastics. It depends on the timeline of the proposed reconstruction, the amputation options available for the patient, and then also the current and the future access to a prosthetic service. Thank you very much. So that's all from my side for now. I'm going to stop my screen here, and maybe I'll just interrupt for a moment. Any questions before we hand over to Jason and Justin? Any questions from anyone? You can put up your hand, or you can just switch on your mic and ask.
Hi Maritz, thanks Marie. I'd just like to ask, you've said you haven't done it before, but in the amputation described the supracondylar one where you actually use the patella as a weight-bearing surface. How do you attach the patella then to the stump?
So normally with two screws. I have actually seen a couple of just cases where that was done. I've never done it myself. So normally people take 2 screws. So you cut the undersurface of the patella to expose the cancellous bone. You put that to the distal femoral stump, and you fix that with two screws through the patella into the distal femur.
Okay, cool. Thanks.
Maritz?
Okay. Yes.
If you are doing a BKA, and the reason for amputation, trauma or sepsis, whatever it is limiting the length of your stump below the knee to below or shorter than what you recommend, the 1 inch per foot story. Would it be then better to go above the knee or through the knee, or rather give that short stump and try and optimize with what you've got?
That's probably the most difficult decision. So to end up with a below knee, with a skin graft or poor cover versus a through knee above knee. And I think there's some exceptions, sometimes in pediatric amputation where they still have some residual growth, but mostly in adults, I think, you can go a little bit shorter, maybe up to 10 centimeters, but it's a too short stump or a stump with just terrible scar tissue and skin graft is actually worse than a more proximal amputation. So rather go for a well done through knee amputation than a below knee where either the stump is too short, number one, or there's very poor soft tissue cover, as in just scar tissue and skin graft, because those people just get a lot of problems. There are some techniques like stump lengthening, precise nail. And I have a very short little nail that's designed to lengthen a stump, but I think that's more to lengthen above knee amputees. I think if the below knee is going to be too short, then or the skin too bad, it's better to go for through knee. But Jason and Justin will be able to give us a lot more insight into that, because that's the sort of problems that they deal with on a daily basis.
Thank you.
Anyone else? Otherwise, I'll ask Justin. You can share your screen, and then we'll start Jason, and then Justin will take over from him.
Thanks. Cool. So good evening, everyone. And Justin's going to do the clicking through. We just thought we'd save ourselves a technical nightmare. So we are Chin Partners, and as Maritz mentioned, we're based at Vincent Pallotti, and we've been there for the last 20 years. We've also got practice at Christian Barnard, and then we've got a prosthetic laboratory or workshop and a rehab facility at Pinelands Business Park. And I think this is one of the factors that limits prosthetic services, is you actually need quite a big setup to provide an effective service. And then you need all the auxiliary staff. You need a psychologist and a physio and an occupational therapist, all with an interest in prosthetics to really provide comprehensive rehab. So we are quite fortunate in that we've got that, and it allows us to provide a comprehensive service. So orthotics and prosthetics is a field that's evolved a lot in recent years as we've moved on from metals and leathers to composite materials and fancy plastics. And it's very diverse, and often clinics and different areas have different patient profiles, and this sort of defines the types of orthotics that one sees particularly. So orthotics is a supportive or corrective device. And, you know, as I said, different areas use different things. Upcountry in Gauteng, for example, they use a lot of spinal bracing post-fusions, whereas in the Western Cape, we don't. So it's often as things are taught in schools. But orthotics range from a simple little mallet finger splint to a complex corrective spinal brace. These, as the market has grown, can be off the shelf as things have been standardized and costs have become a huge factor. Or in many cases where there's weight concerns or you've got long-term wearing of a device or you need complete immobilization or specialization, then we customize the devices. And our indication as an orthotist or as a prosthetist is to find out from the orthopedic surgeon, what is it that they want? You know, how long do you want to immobilize this leg for? What sort of correction do you want to attain? What sort of function do you hope this person to perform inside the device? And that allows us to then design an effective orthosis. We have a range of different types of hinges, materials, and manufacturing techniques that allow us to design and manufacture a huge variety of appliances. So nearly impossible to get into all the types of orthoses, but just to really try motivate everyone to engage with the orthotist, prosthetist in your area. Often as orthotists and prosthetists, we feel quite intimidated until we get more comfortable with the surgeon and there's a better understanding. And it really allows us to excel in patient care. Off-the-shelf devices, as I said, a lot available and often a lot more functional than using the old school plaster casts. Here's an example of some of the most commonly used braces. The big one in the middle, the ROM knee brace, a very effective brace, but in my opinion, overused. You know, the thing that makes you not bend your knee most is that the thing slips down your leg, so you really walk gingerly with it. And it should only be used as an immobilizer and as a post-op brace. You get highly effective knee braces, which, like an osteoarthritis knee brace, where you can unload a medial compartment of an osteoarthritic knee for years and years in a patient if they're too young, until they've really worn that knee down, and then perform a knee replacement. We've got examples of simple ankle braces, moon boots, elbow ROM braces. These are some of the very commonly used braces, and we use them both post-operatively and then return to activity. A lot of orthotics are really very useful in the early stages of rehab where the person is dying to get back to activity, and it's often at this point where your surgery is really only settling down, and using an effective orthotic can really help the person return to function, using the leg with confidence and better load bearing and better body balance, and improves the function. The next slide is an example of some of our custom-made devices. The little kid in the corner there, that's a cranial remolding helmet for kids with head deformities. Something we do a lot of is foot orthotics, which if made properly can relieve a host of foot and ankle conditions, and can even be wedged to shift lower limb alignment for osteoarthritis or realigning of the joints higher up in the line. That picture in the middle there is a carbon fiber ankle foot orthosis. It's got a carbon strut that goes down the back. This allows energy return and a very effective brace. We often use these in failed ankle replacements, severely arthritic ankles. this is actually a hybrid between a below-knee prosthesis, where you've got patella tendon weight bearing, you've got weight bearing along the medial and lateral aspects of the tibia, and then you're immobilizing the ankle with a strut along the back to provide energy return. The image on the right is a standard ankle foot orthosis, hinge brace, often used for your drop foot patient or for your various ankle conditions. This is a dual system brace where you'll see that the inner foot piece is a flexible plastic that can immobilize the foot in whichever position is going to be best for that patient, but it allows you to then lock the foot back in the brace. And then down at the bottom, we've got a big custom-made, it's probably a Perthes brace with the strut holding the legs in abduction. We've got hip joints and a whole pelvic girdle. So really, we can follow whatever prescription within reason that the orthopedic surgeon provides us with, and there's generally a brace that can support that or that part of the body, whatever it may be. So I think we just wanted to briefly touch on orthotics, and then we're going to move over to prosthetics. And when asked to discuss prosthetics with orthopedic surgeons, we've had a talk before, and it's really, as a prosthetist, the urging is for the orthopedic surgeon to provide us with the best possible stump. The better the stump that we've got to work with, I suppose it's selfish, but the easier our job is, but it is the quicker, and with the less hassle, the patient can live the rest of their life. So often spending an extra 20 minutes to move a suture line or to bevel a bone or whatever it may be can have a life-changing effect on the patient. So Justin's going to talk to you about prosthetic considerations in amputation. The objective is definitely not to be telling anyone how to do an amputation, because it's really, we're talking outside of our expertise, but really what we as prosthetists would like the surgeon to consider as prosthetic considerations for amputation. So Justin's our lead prosthetist, and he'll be talking to you guys, and we welcome any questions at the end. Thanks.
Cool, thank you, Jason. I hope everyone can hear me properly. So if we're looking at prosthetics, we look at upper limb and lower limb, and we're looking at major and minor amputation. So minor being a toe or a finger, and major being a transradial or transtibial amputation. When we're looking at upper limb, we are looking at four different types of prostheses essentially you can get. Cosmetic, body-powered, myoelectric, or we are looking at pattern recognition, which is some of the newest technology that's coming available on the market today. For lower limb, we are looking at various different amputation levels again, with major and minor. And for things that are important for us that we look at, we are looking at residual limb length. So as Maritz spoke about bone length, how we're going to be able to suspend a socket off a residual limb. The majority of the medical aids now are working with an AMPRO system. So AMPRO is a amputee mobility predictor tool. You get one with the prosthesis being pro, or no pro being no prosthesis. These are then broken down into different levels, K0 being a person who's non-ambulatory and goes K1, 2, 3, 4. K4 isn't necessarily an athlete, it could be just a highly functional amputee. And this is what a lot of the medical aids are using now to classify amputees for how they're going to do their funding. So as much as you want to give the patient the best of everything, a lot of it obviously comes down to funding. So you've either got state or government, COIDA, which is workman's compensation, medical aid, RAF, and then private. So that's how we are looking at who's going to fund the prosthesis. as Maurice spoke about, he spoke about traumatic amputation. So for us, we tend to see amputations not only from the orthopedic side. Obviously, there's disease, we've got vascular, osteomyelitis, etc. So we've got, yeah, there's quite a bit that we can also look at as in congenital abnormalities. So for us, from a prosthetic point of view, again, we're looking at the again, as Jason said, from a selfish point of view, we're looking at what we can get best from the surgeon. So we see amputation surgeons having a unique role and responsibility. When facing any surgical case, the surgeon, we feel, must strive towards two main goals, both of which are quite critical to the success of the procedure. The first goal is the removal of the disease, damaged or dysfunctional portion of the limb. And the second goal is the reconstruction of the remaining limb. Reconstruction must promote primary or secondary wound healing, as well as create the most optimal sensory and motor end organ possible. The reconstructive nature of amputation surgery and the potentially positive impact that the proper technique can have on an individual's post-amputation function cannot be overemphasized in this case. The success of every amputation surgery depends on the balance between these two main goals. To be effective, the amputation surgeon must understand not only the surgical principles, but also the aspects of the healing, rehabilitation, residual limb physiology, and the nature of the prosthetic substitutes. So I'm going to touch on the main areas that we believe the actual surgery has the most impact on the ultimate comfort and function of the prosthesis. This is the level of amputation, bone length, the condition of the skin, and the muscles. So these are a couple of the major amputation levels. If we could choose, then the lower level of amputation would be better. This because it has a better functional outcome, but each level has its own challenges along with its own benefits. From an energy expenditure, a BK amputation is the most efficient, and I'll briefly discuss this on the next slide. Traditional amputation levels were developed over the ages, as Maritz has spoken about, through a process where surgeons have passed down knowledge and lessons learned concerning specific techniques. The best techniques provided the fastest healing and best padded stump, as well as a stump that could retain its physiology. For an AK amputation, the longer was generally considered better, and for a below-knee amputation, we were always taught and told about surgeons using a 4-finger roll, 4 fingers below the tibial tuberosity, and this is obviously not always the case. As a prosthetist, we want a stump that is long enough that we can comfortably fit a socket with, but not too long that we have issues with the components fitting in the space between the bottom of the stump and the ground. So when it comes to energy expenditure levels, we've got the slide that we took from the University of Leeds, and as you can clearly see, the higher the level of amputation, the more energy is required to power the prosthesis. But it's not only powering the prosthesis, it's balance, coordination, and controlling of the prosthesis. What is the weight of the various components that come with the prosthesis that we need to look at? So I thought we'd speak a little bit on the components. So these are some of the components that we will find in a prosthesis. So on the left, we've got a pin lock system, and this is a silicone liner. And on the right hand side, we've got it's also a suction system, again silicone liner. These are rolled onto the residual limb, and it provides a barrier between the residuum and the hard socket. And they vary in thickness, so these are between 3 and 6 millimeters, depending on the make. And they tend to be a little bit thicker at the bottom to give a little bit more cushioning. They can be up to about 14, 15 millimeters thick. So taking that into consideration, the thickness at the end of your liner, you then have to either fit in a lock, in the case on the left-hand side, or a lamination anchor and a rotation adapter. So all this adds space below the stump. So ideally, we are looking for a sort of a minimum length below the end of the stump between the center of the knee, roughly about 10 to 15 centimeters. If you're looking at this, just to take an example, this particular knee, from the knee center to the top of the pyramid, we're looking about 45 millimeters. We then, if we can fit in a rotation adapter, that's another 20 millimeters, and then we would fit in a rotation adapter. These are quite critical for us because it allows us to change our alignment. So once the socket's completed, to make alignment changes to a prosthesis can be quite difficult. We call them get out of shift adapters for obvious reasons. We can make small adjustments to increase alignment. There's other methods to suspend prosthesis. These are just two of them. You can get skin suction, where this is used a lot in the government for transfemoral amputees, where you have direct skin suction between the socket with an expulsion valve. So you pull the limb into the socket and a valve will then seal at the most distal end of it. And you can use socks, and so you put a literal woolen sock over the residuum, and then you'd use either a PTB strap in the case of a below knee amputation, or a Silesian belt in a transfemoral amputation. Again, a lot of this boils down to funding as to what type of knee you're going to use, what type of liner you're going to use, and what your components you're going to use in between. The next slide is a transtibial prosthesis, and this is just an example of one that we made, and this is what essentially your prosthesis is going to comprise of. So you can have a flexible inner socket, which provides a little bit more cushioning between the liner and the hard socket. This particular one has a suspension lock. If it was the suction system, you would have a little valve, residuum goes inside the socket, and then it blows out of the one-way valve. From there, we've got the lamination anchor we spoke about, the pylon, and the foot. The carbon fiber foot, in this particular case, is a C-shaped blade, but all feet will differ. You can get, depends on your activity level and the function that's required. So if the stump is too long, this limits the type of feet that we can use underneath there. There is a variety of feet available on the market, but the higher the build height in this particular case, the more energy we can get out of the foot. So this is an example of a transfemoral prosthesis. Again, flexible inner transfemoral socket and the hard socket with a lamination anchor, the double female adapter, the rotation adapter. In this case, we have a very, very nice knee. It's a Genium X3, which is a microprocessor knee, so a very intelligent knee. We then have the pylon and the carbon fiber foot. So what we're really looking at when we're looking at our residuum is the bone. So on the left-hand side, we've got a very short below knee stump. This makes it very difficult to power the prosthesis with such a short lever. Yes, you're saving a joint, however, it makes the suspension of the prosthesis extremely difficult. We'd most likely have to use hinges and a thigh corset to provide medial and lateral stability to the prosthesis, for the prosthesis at least. Then on so in this particular case, a knee disarticulation prosthesis could have been a better option, or it would have been more functional. in our opinion. As with the 3-knee, you've got the ability to bear weight at the end of the stump, and there's less traumatic edema post-surgery, as there's no cutting of the bone. And they are usually able to up onto a prosthesis a lot faster than a below-knee amputee. Then the image on the right is a long transfemoral amputation. This particular surgeon amputated just above the condyles, which left a very sharp bone and very little space necessary for prosthetic components. And essentially they've been treated as a 3-knee amputee without the ability to bear weight at the end of it. So now we've got a problem fitting the components in it. So the length of the residual bone is important. Increasing the length of the residuum by leaving excessive soft tissue isn't. We've got a case where we've got a lady that came in which looked like a perfect length transfemoral amputation with a nice long lever arm. But when we started actually palpating the stump, we realized that the femur was actually in fact very short, and half of it was made up of soft tissue, which offers nothing other than elongating the appearance of the stump, which makes it extremely difficult for her to don her liner, and because she has to then control the soft tissue with the liner. So a revision surgery will most likely be indicated. Well, time will tell at least. And again, going to bone tissue. So this is what Jason spoke about, talking about beveling the bone. So proper foresight and attention to bone preparation can eliminate potential areas of high pressure of the bone against the socket. So for a below-knee amputee, a common site of discomfort and skin breakdown is the distal anterior aspect of the tibia. This is because the tibia helps drive the prosthesis forward. And this is often commonly due to inadequate contouring or beveling at the tibia at the time of the amputation. Although we can relieve this with a bit of socket relief, it shouldn't really be necessary, and it should be a standard consideration, in our opinion, during surgery. Again, we understand if it's emergency surgery, going back to it at a later stage to revise it would be a better option for the patient. Again, if the fibula is left longer than the tibia, we have an issue at the distal end, and it makes weight bearing quite difficult. Again, socket modification can be attempted, but often surgical revision is necessary in that case. In very short transtibial residual limbs, if the fibula head and the shaft are unduly prominent or hypermobile, the fibula at least may require secondary resection in that case. All right, next slide. So this is actually one of Maritz's patients. He was involved in a road traffic accident, and he lost his leg, and he came down to Cape Town, and I think he saw Maritz after the initial amputation, and there was infection at the distal end of the bone. Maritz and I had a chat about whether we should go for a 3-knee, because he was worried that if he was going to take off a few centimeters of the distal end, because there's already a short residuum, that we'd have issues with suspending of the socket. In this particular case, we suggested that he sticks with the below-knee stump and not go through to 3-knee, which he's fitted quite successfully. Unfortunately, due to COVID situation, the gentleman picked up an extra 26 kgs and the socket no longer fits. So not an ideal case. Then at the bottom picture is a modified Van Ness rotationplasty, which is great for distal end weight bearing. However, this posed quite a few fitting problems due to the stump shape and the increased length, which meant that the knee centers were very different, which made his stride length and timing uneven. The increased stump length also posed various problems for him to sit in the car, sit in the movies, especially when there's limited space in front of him when he was required to sit. However, some creative surgery can also help. Again, case study, patient at least. We had a lady that had a tumor removed where the surgeon was able to keep a portion of the femur, well, had to remove a portion of the femur and the lower limb, and he used the head of the distal end of the femur, which was able to reattach, which resulted in a sort of an end weight-bearing knee disarticulation with the appearance of a mid to long transfemoral amputation. It's made a very big difference to the patient, as she didn't have to worry about a seat for the ischium to sit on, as well as it allowed us to get our knee centers more level, which was a huge benefit for her. So we've got the two pictures on the left-hand side. This is a transfemoral amputation, showing the length of the residuum, and then we've got the actual knee centers itself. So we've got a good length residual limb. We have plenty of space to work with to fit the components underneath. And it's a long enough lever arm to help power the prosthesis during the swing phase. The shorter the lever arm in a transfemoral amputee, or any amputation at least, it makes it more difficult to drive it forward. Then on the image on the left, we have a knee disarticulation. Although this amputation allows the user to end weight bear, it has its drawbacks too, where we have our knee center much lower on the prosthetic side than on the sound side, which makes the aesthetics a little bit tricky for the patients, as the knee will stick out a little bit further. But the prosthetic advantages outweigh the disadvantages in this case. So we've spoken about the bone, we've spoken about the bone length. So now we go onto the skin. So these images indicate where pressure tolerant and sensitive areas, whereas the green is tolerant and the red is sensitive. So for us, care should be taken not to place suture lines over bony prominence or subcutaneous bone. The more skin surface available for contact with the prosthetic socket, the less pressure will be applied to each unit area of skin. So in transfemoral sockets, we are generally rely on the ischium as our primary source of weight bearing, along with associated hydrostatic pressure. There are different design methods that have been tried, from plug sockets to quadrilateral sockets, ischial containment, and even ramus containment. We generally use a bony lock with the ischium, and counter pressure come from the anterior lateral aspect of the socket. A lateral pressure is required along the femur. This is to keep the distal lateral aspect away from the end of the socket. If there's too much pressure in this particular area, we end up with an osteophyte buildup. So as I spoke about earlier with the silicone liners, we use silicone or gel to help protect the skin. But even with this padding, the skin is still subjected to constant pressures within the socket. And this is where we use a hybrid total contact socket to distribute forces over the entire surface of the stump, as well as targeted weight-bearing areas. So if we're looking at a transtibial amputee, we can take, if we're looking at the anterior view, we can take sort of pressure in the mid-patellar tendon, along the medial aspect of the tibia, in between the tibia and the fibula, as well as the lateral aspect of the fibula. socket designs have evolved and continue to evolve to improve pressure tolerance and so far, and by doing that, socket comfort. So we then move on to the grafts, scarring, and bony overgrowth. Again, Maritz covered a little bit of this earlier. So along with the fasciocutaneous flaps and free flap techniques, the skin grafts are a viable option in modern amputation surgeries and prosthetic fittings. It is possible to use split thickness grafts to hold under the forces. They generally can hold under the forces applied by the prosthesis, but the grafts will be most successful when they're not adherent to bone. Application of the graft over a cushioned mobile muscle bed is ideal. However, if the skin grafts are in sockets in a pressure zone like the distal anterior aspects of the tibia, then chances are they'll break down and limit the amputee's function, such as the picture on the bottom right. Invaginations and skin folds often cause pressure areas within the sockets, as well as with those voids, you tend to have a lot of sweat buildup, and obviously a lot of moisture inside the socket isn't a good idea. Then we move on to the muscle. So again, Maritz covered a lot of this. So again, from our point of view, the muscle makes up the bulk of the residual limb soft tissues. So the amputee with a muscular wall pattern balanced residual limb is less prone to chronic pain syndrome, and the maximum retention of the function muscles is essential to provide the residual limb with effective strength, size, shape, circulation, and metabolic exchange and proprioception. So the proper muscle function depends on the anatomic origin and insertion of the muscle. Without fixed resistance against which a muscle can forcibly contract, progressive weakness and atrophy may develop or will develop. Distal muscle stabilization is a primary principle of amputation surgery. Wherever possible, the section muscle should be attached and stabilized in order to retain the muscle function and to improve the coverage of the distal padding of the bone. So myofascial closure in itself is not a really effective means of muscle stabilization, as it only provides minimal stabilization and for the most superficial muscles, and provides inadequate distal attachment of the muscular tissue to the bone. With myoplasty, the muscles are taken over the end of the bone and sewn to the opposing muscle groups. Is also not effective in most cases unless these muscles become firmly stabilized by scar tissue. The problem is that the attachment can work antagonistically as a muscular sling, sliding backwards and forwards at the distal end of the bone, which this can cause bursal tissue and discomfort. And then we're looking at myodesis. It's ideally what we want. The muscle groups themselves are attached directly to the periosteum, and the deepest layers of the muscle are typically secured directly to the bone, while the more superficial muscle layers are sewn to each other as a myoplasty. The myofascial envelope is then closed over the top of this muscular reconstruction, and then tenodesis is most commonly used in disarticulations, and primarily in knee disarticulations. This slide, I think Maritz wrote very much the same. So if we're looking at this picture over here, this is a lady, well, like it's a prime example of what we had with that lady, where they had a very short femur and lots of residual soft tissue. What ends up happening is that we have limited control of the residuum within inside the socket, because it's taken away a lot of the stabilizers. This affects alignment, and we start losing control of the lever. She would end up with quite an adductor roll, and would have some issues with her circumducting as she goes through the swing phase. and there's a lot of lateral pressure as we and against the distal end of the femur. The nerves. So this is another issue we tend to experience. So the development of stump neuromas at the end of the severed ends of the major nerves, the ability to define them and distinguish them from the other causes of stump pain is a considerable clinical significance. A neuroma is a tumor-like thickening of the nerve stump in the region of the scar after amputation of a limb, and is tended to pressure. Even with only mild stimulation, neuromas transmit strong pain signals, and if local measures to relieve them aren't inadequate, it may be worth considering a surgical removal of the painful neuroma. It makes our job extremely difficult to mold a wall fitting socket, and then once they've removed, they can of course reoccur. Vision amputation. Well, as a prosthetist, we work hard on adapting the client sockets to try and ensure and prevent revision amputations. Sometimes it's not always possible. Revision is necessary if the primary amputation fails to heal, or else if the residual limb is unsatisfactory for prosthetic fitting. Revision may also be necessary if the residual limb does not serve the patient's functional requirements. We had a patient who had a transtibial amputation following a road traffic accident. We struggled for years trying to get him comfortable, and as he kept on having skin breakdown at the distal end of his residuum, despite all the silicone gels and liners that we had tried to get him nice and comfortable. I think we were the third practice that he had gone to try and relieve his socket discomfort. We eventually spoke to him and asked him to go back to his surgeon and consider a through-knee amputation, which he then agreed to. Within a few weeks, he's finally walking comfortably, pain-free, and his whole mental outlook on prosthetics changed, and towards his work, he was able to walk much longer and much further. And yes, we lost a functional knee joint, however, we gained socket comfort and his ability to be able to ambulate without worrying about the constant skin breakdown. So again, this works to our favor. So post-operative management, obviously very important. So each surgeon will have their own preference as in terms of what their post-surgical dressings will be. So soft or rigid. We find that soft is the most common. But we find that care must be taken post-surgery to prevent edema and positioning of the limb to help prevent flexion contractures. With the aid of the pressure applied to the residual limb over a large surface area, the swelling can be reduced and the residual limb can be formed in a better shape for future prosthetic fitting, and which we refer to as coning. The amount of the resultant traumatic edema determines when the patient can be fitted with a prosthesis. We generally fit the patient with their initial socket 8 weeks post amputation, but the residuum can still take up to 18 months to settle, and even then still not 100% settled, as weight gain or loss, as well as activity levels, can cause the residuum to increase or decrease in size and in volume. Generally, the amputee will receive multiple sockets in their lifetime as a prosthetic user. It's not unusual for a primary amputee to require new sockets within 6 months after their first socket. As prosthetists, we try and increase the lifespan of the socket by padding the inside of the socket, applying polyurethane rinses, or using stump socks to take up the space within the socket until eventual refit is then required. By limiting the initial swelling within the limb post-surgery, this reduces the time taken for the residuum to stabilize and the prosthetic aspect of the treatment to start. We often come across residual limbs that have been incorrectly bandaged, especially transtibial amputees where the bandage starts below the knee. This ends up causing a tourniquet effect where the distal end bulges and there's no graduated compression. So we feel that the post-op management of this is vital to ensure a smoother process post-surgery to prosthetic fitting. Then if we're looking at physiotherapy and the prosthetic outcomes, we believe, as Maritz spoke about it earlier, in a multidisciplinary approach for the post-operative management with rehab post-amputation to maintain an increased core strength. This is to make sure that they are well prepared for the next treatment steps. Having a physical therapist show them exercises which support their recovery and also trainer joints near the amputation location. The type and higher the level of amputation, the more involvement we feel with the physiotherapist is required. Not only does the level of amputation affect the energy expenditure, as we discussed earlier, it also affects the muscle and cognitive involvement to ambulate. With hemipelvectomy amputees, they rely on the upper body to propel the prosthesis forward. They have a prosthetic hip, prosthetic knee, and an ankle joint that doesn't move. So they have to control all these components to sit or stand. Something that is instinctive to us requires a lot of concentration and effort and sensory awareness for them to ambulate safely. So therefore, the physiotherapy side of it and the rehabilitation is very, very important. Psychotherapy, equally as important. The emotional support to help during the grieving period with the loss of the limb and the readjustment to the new image, as well as addressing the psychological impact at the early stage has proven to enhance the amputee's rehabilitation process. The goal of rehabilitation after an amputation is to help the patient return to the highest level of function and independence as fast as possible, while improving the overall quality of life, both physically, emotionally, and socially. As Maritz mentioned, our practice, we work closely with the Cape Amputee Clinic, where we have a multidisciplinary team again that helps address all these aspects of amputation for both the patient and their family. Okay. Just an example of the soft dressing that we spoke about earlier, and then the rigid dressing. The soft dressings are most commonly used. With the rigid dressing, it's quite nicely. We have less edema, and it helps protect the stump better, and helps also should they fall, you get a bit better protection. So we prefer this. Obviously, this is dependent on what the surgeon prefers. It's not always up to us, but that's what we prefer. I'm going to touch briefly on upper limb amputation, upper limb amputations. Not going to spend a lot of time with prosthetics. There's quite a bit to go through. I'm trying to keep it fairly concise. So again, with upper limb amputation with upper limb amputation, we have similar considerations to look for lower limb amputations, where we have severe scar tissue, especially with myoelectric prosthesis, because you rely on a good residual limb to place your electrodes, bony prominences, excessive soft tissue, hypersensitivity, and too short residual limb. We have issues with our prosthetic suspension. And then also, again, the space required to put all these components in. So if we're looking at upper limb, we can pretty much look at cosmetic options. This is just trying to make it look like a natural arm and hand. Because there are no functional elements to this prosthesis, we find that they are obviously very lightweight, and they especially suited to they're very well suited for high amputation levels. Body powered. This is a harness system. This is one of the prosthetic limbs, upper limb prosthetics that you see the most, and these are controlled by harnesses. We have a voluntary opening hand or hook, which are interchangeable, as well as the elbows, amputations, where you can use the harness to unlock or lock the elbow to get the required position. My electric, this has been around since the 1960s. We use electrodes, normally two, one for opening, one for closing, for the flexor extensors. And yeah, it's, this again goes down to funding, a lot more expensive than body harness. And then we start looking at pattern recognition. So this is one of the new advancements in prosthetics. So a mental image is often kept post amputation of how the hand would move as mapped in the brain. So the amputees can still imagine closing and opening, rotating their hand, and these activities sort of remain in the muscles of the residual limb. So then these muscle signals are then transferred into myoelectric signals, which are picked up by 8 electrodes on the forearm, and then they're translated directly into a movement of the prosthetic hand. So the system learns to interpret the user's individual movement patterns. So if you're pointing a finger, opening and closing your hand, and then it assigns us to a specific movement within the prosthesis. And they're very intuitive, these patterns, and they can be adapted to fully utilize the potential of this highly complex prosthesis. They're also currently working on systems with transhumeral amputees where they are able to control not only the wrist and the hand, but also the elbow. Okay, so in summary, I know I've been through this very quickly. So we've got the 6 stages of the process. We call it step 1 is the preoperative counseling and education. We'll be preparing the patient and equally important, the family for the process ahead. The patient is usually made up their mind in elective amputation, but the family sometimes takes a little bit more convincing. And then we're also looking at of what's going to happen and what they're going to expect. So this is where a amputee clinic comes into effect. So the perioperative incorporation and coordination, this is step 2. So this is ideally where the surgeon and the prosthetist coordinate to plan the best amputation where permitted, and having a good communication with your prosthetist in this regard has the benefits can be massive, especially for the patient. And then we look at step 3, which is our post-operative care. This is where we're looking at protecting and monitoring the residual limb, so with rigid dressings or soft dressings, and as well as positioning in the bed to prevent infection contractures, as well as bedside assistance and care to prevent the falls. Step 4 is post-healing rehabilitation. This is working with a physiotherapist and occupational therapist to help with conditioning and strength. So being able to maneuver around the house to make a cup of tea or coffee, or preparing dinner, showering, etc., all while being safe. Step 5, prosthetic evaluation and fitting. So working with the patient's existing comorbidities to design and deliver the correct type of custom prosthesis for their daily needs. This would be based on the AMPRO that we spoke about earlier, environmental factors that could be if they need a waterproof prosthesis, if they're fishing or swimming, or it could be safe knees for vulnerable or elderly users in transfemoral amputees. And then stage 6, and this is probably the best day for us as a prosthetist, seeing the patient stand and walk. They're often so engrossed with the fitting that and the new sensations, they don't often realize that they've walked for the first time in weeks or months. And when you point it out to them, the realization on their faces makes it all worth it for us. So this is actually a patient. He was involved in a road traffic accident, and the surgeon discussed the residual limb length with Jason, and we worked out what would give him the optimum length of his leg at the level of the amputation, and as to fit in all the components below. He's a cyclist, and he enjoys his hunting, and he uses his leg for various purposes, as you can see. Yeah, thank you very much for listening.
Brilliant, Justin. Thank you very much. That was very useful. I like this last picture. I really like that last slide as well, with the different stages of the process. We'll ask for some, give opportunity for some questions. I just maybe want to also just stress, you made some very good points there, that you know, skin graft is not necessarily a problem over a stump if it's a well padded sort of above knee with muscle around the stump, versus in a tibia where it's just sort of skin graft stuck to the tibia without much soft tissue. That's a bigger problem. And then just you know, to pick up from what you said, you know, if you don't do a myodesis of your muscles, it's been shown on MRI studies that up to 70% of the muscle atrophies. So they're very important to maintain the function of the muscles to do a myodesis. Any questions from any of the regs for Jason or Justin? Just put your hand up, or just unmute your microphone. Justin, while we wait, just sort of as a ballpark figure, out of interest, sort of a standard, not a like extremely high performance, but a prosthesis for a below knee amputee nowadays in private practice, how much would that be?
Depends on the level of the what type of foot you're going to use, but you could probably say about 65 to 80,000 would be a sort of a standard. That would probably be considered sort of K1, K2. You're probably looking, or K2, K3. You're probably looking close to about 100,000, and K4 probably about 120, 125,000.
Okay. And just a question earlier about a through knee amputation, you know, and trauma versus a short below knee versus an above knee. Is a through knee still a good choice of you? Would you?
For sure, yes. No, we still prefer a through knee. As we said, the advantages of the through knee far outweigh the disadvantages with limb length. Again, we have less issue. I find we have less issues than a transfemoral amputee, as in they don't have to rely on the ischium for weight bearing. So yeah, I would say if you're going to look at it, if it's either going to be you can manage a knee disarticulation, then rather go for that than a transfemoral amputation.
Better below knee first.
But you better below first, yes.
Far long shot.
Yeah. With enough limb
Far
length.
long shot. Even from a costing perspective, the knee component is very expensive, especially in higher functioning amputees.
Okay, so that's expensive, but any other questions? Any questions for Justin or Jason? Great. So Justin, Jason, again, thank you so much for making time on a week evening, and we really appreciate it. That was very informative, and thanks a lot. Really appreciate it.
Thank you.
Thank you.